Good morning, good afternoon, good evening, and welcome to our IASP PRF webinar. I'm Renee Chassie, IASP's Publications Manager, and today we are excited to bring you a webinar produced by IASP's Acute Pain Special Interest Group titled Upskilling Pain Relief After Surgery, Perioperative Behavioral Intervention Efficacy and Practical Considerations. The publication that inspired this webinar was published today in Regional Anesthesia and Pain Medicine as part of their special issue called Tackling the Challenge of Chronic Post-Surgical Pain. I will be posting the link to the article and the special issue in the chat, and I encourage everyone to take a look at both of them following this event. Today, we will be hearing from Dr. Madeline Peters from Maastricht University in the Netherlands, Dr. Katie Hadlin-Smith from the University of Iowa in the US, Dr. Samantha Meintz from Brigham and Women's Hospital in Boston, Massachusetts in the US, Dr. Beth Darnell from Stanford University in Palo Alto, California in the US, Dr. Sarah Davin from the Cleveland Clinic in Ohio in the US, and Dr. Rianne van Boykel from Radboud University Medical Center in Nijmegen in the Netherlands. Thank you all for bearing with me during that one. The IASP PRF and Special Interest Group is thankful for everyone who could join us today and remind you that today's webinar will be recorded and available for later viewing at IASP's Pain Education Resource Center. I'd also encourage our viewers to utilize Zoom's Q&A feature to ask any questions you may have during today's proceedings. At this time, I'd like to introduce Rianne van Boykel. Rianne is a skilled nurse, educator, epidemiologist, and researcher who earned her PhD from Radboud University in the Netherlands in 2017. Currently serving as an assistant professor at the Department of Anesthesiology, Pain, and Palliative Medicine. Her research centers on acute postoperative pain management, as well as the prediction, pain, and pain services. With that, I'd like to pass today's proceedings over to Rianne, and I look forward to hearing from everyone. Thank you so much.
Thank you, Renee, for this kind introduction. So, hello, everybody. And I'm the chair of the Special Interest Group Acute Pain of the IASP, and on behalf of our SIG Acute Pain, I would like to warmly welcome you to today's webinar. As you may know, the Acute Pain SIG advances and promotes the understanding of mechanisms, assessment, prevention, and management of acute pain, and the contents of this webinar fit our mission perfectly. So we are very thrilled to have such a diverse and engaged group of professionals here with us, representing a wide range of disciplines and expertise in the field of pain management. Throughout today's webinar, we will be covering perioperative behavioral interventions with randomized controlled evidence, supporting efficacy for extending analgesia after surgery. And we are featuring expert speakers who will share valuable insights, research findings, and practical approaches. So we encourage you to participate actively by putting your questions in the Q&A sections, so we can make the most of this interactive session. I will moderate the Q&A session after we listen to the presentations of our 5 speakers. Before we dive in, I would like to take a moment to thank the IASP for their support for organizing this event, and to all our speakers and participants for their contributions, of course. So we hope that you find today's webinar informative, thought-provoking, and inspiring. So without further delay, let's get started. So I will hand over to Madeline Peters for now. Madeline, the floor is yours.
Okay, thank you, Rianne, and welcome everybody to this webinar. Good afternoon, good evening, and I will start sharing my slides. At least, I hope. Here, okay. Sorry for this, takes a little bit longer, and probably you don't see the correct one now.
Only the presenter mode, then it's ready, Madeline.
Okay, presenter mode. Okay, now you see the presenter mode, or do you see the notes as well?
It's coming. It's still
coming.
turning.
Okay. Okay, I will introduce
There
myself.
it is.
Okay, then there we are. So I will introduce myself. My name is Madelon Peters, and I'm from Maastricht University, where I lead a group of experimental health psychology, and we mainly do pain research. And my specific interest is chronic post-surgical pain. So what I will do is first talk about, well, first I go back to this slide. I'm going to talk about the need for accessible and effective interventions in post-surgical pain and why it's important for the relief and the recovery of pain after interventions. So what I first will do is talk about why there is this need of perioperative interventions. And what I can say is that despite improvements of post-operative analgesia in the last decades, there is still a very high prevalence of severe acute post-surgical pain. And for instance, we have this data, that's from the Pain Out study, and that's a large European registry where they looked at the pain immediately after surgery, well, at least the first day after surgery, in a large cohort of patients. And this is across many sites in Europe and many different countries. And you can see there's a very large cohort of patients involved in this study. And what they found was that at the first post-operative day, 25% of patients reported a high intensity or at least even severe acute post-surgical pain, 25%. And that was one day after surgery. So that's a huge prevalence. And also what we know is that having high acute post-surgical pain is also a risk factor for developing chronic post-operative pain. And especially if the pain doesn't go away in the first week, so if it persists for a longer time. And also, there is a high prevalence of chronic post-surgical pain. And here again, I have some data from the Pain Out study across Europe. And what they did here was look at how many patients, having had an operation, still reported pain either at 6 or 12 months later, so two different studies. And you can see that also a little bit of variation in how they defined having the prevalence of post-operative pain, either more than 3 or 3 or more, so a little bit of variation there. But anyway, despite difference in timing, despite difference in definition, they found exactly, well, almost similar prevalences across these studies, namely that 11 to 12% of all of their patients still reported having pain at either 6 or 12 months after the operation. And of course, you might imagine that it also varies depending on what kind of surgical intervention has taken place. For instance, orthopedic surgery and thoracotomy have a higher prevalence than eye surgery, as you can imagine that. But still, across average over all these interventions, there is a large 10% of prevalence of chronic post-operative pain. We already do know a little bit about risk factors for chronic post-operative pain. I already mentioned that having a high level of acute post-operative pain is one of the risk factors, but also having any chronic pain conditions before surgery or using opioids before surgery, there are risk factors for having a higher chance of developing chronic post-operative pain. But also, in recent years, many studies have come out that also show that psychological factors may impact this risk and may heighten the chance. And by now there is quite a few studies for a variety of surgical interventions, and across these studies, the same factors have been found over and over again, and they also are summarized in meta-analysis by now. So it's mainly anxiety around time of the operation, trait anxiety or more specific anxiety of the operation. It is also worrying about pain or worrying about the operation, also called pain catastrophizing. And also depression has been found as one of the risk factors. So you can imagine if these psychological factors do play a role, if we could intervene on these factors, that it might also mitigate the risk of developing chronic post-operative pain. And in fact, it's already more now, almost 15 years ago, that Burns and Morridge published this paper, which was actually a theoretical paper, where they proposed that if you give patients cognitive behavioral therapy around the time of surgery, that it could decrease their risk of developing chronic post-operative pain by 50%. As I said, it was only a theoretical paper and kind of a mathematical calculation that they came to this 50%. At that time, there was no data available yet. But fortunately, by now, we have had some RCTs which actually looked into whether perioperative intervention can have this preventive effect. And in fact, there are two very recent papers, one systematic review and scoping review. And in fact, the scoping review by Beth Darnell and her colleagues, that's actually the inspiration of this webinar. But we did 2 years earlier, we did a systematic review, and we looked at both outcomes in terms of acute and subacute pain and disability, but also chronic pain and disability. And we were able to include 11 studies on the acute outcomes and 16 studies on the chronic outcomes. And as I said, we looked at pain intensity, but also at pain disability. And what we found is that there is a significant effect across all these different kinds and different types of psychological interventions for indeed decreasing both acute and chronic pain and disability. And the effect sizes we found were in the range of 0.26 to 0.43. So you could say small to moderate effect sizes. But this was averaged across all kinds of different intervention, and we did not specifically look at which interventions were successful and which weren't. So now, and in fact, this is the inspiration of this webinar, we have this scoping review who much more looked into depth which of the interventions can have a lasting impact. And they identified that 4 interventions indeed can have a more long-term impact, but you will hear more about this in the later talks. Okay, so effectivity is one thing, and we have some effective interventions, but another aspect is, of course, also the feasibility of implementing this in clinical practice, making it accessible for patients. And there, of course, I don't have the answer. Getting from research findings towards implementation is really a huge step. But I can give some suggestions where at least you design an intervention where you have to take into account. And for one thing, this is the duration of an intervention. And you can imagine that if you have a very long intervention of 16 sessions, for instance, around the time of surgery, that would be quite hard to implement it in clinical practice and make this feasible. So I think we need relatively short interventions where we have a balance between having sufficient effective elements and feasibility, shortness, so that you can implement it. Also, you can think about the mode of delivery. Face-to-face intervention might be less accessible because patients need to travel to either the hospital or the intervention location where it takes place. And especially for patients living in more remote areas, this might be a big barrier. So you could think of more accessible modes like online interventions, digital interventions, or by telephone or by video calls. One thing which is, I think, more a discussion point is if we have an intervention, should we target all patients undergoing surgery or specifically focus our intervention on those patients who have a heightened risk of developing chronic post-operative pain? So the patients having high levels of distress and anxiety around the time of surgery, either before or right after surgery. So this is there is pros and cons of specifically targeting at-risk patients. At the moment, I'm involved in 2 randomized controlled trials where we are testing perioperative intervention, one in lumbar fusion surgery patients and one in breast cancer surgery. They're still ongoing, so I'm not going to present any results here, but you will hear that results from other studies in the later talks. But what I'm going to go into here is how we try to make these interventions as accessible and as feasible as possible. So regarding duration, we try to make it relatively short. So 5 sessions in the breast cancer case and 6 sessions in the lumbar fusion case, where we have 1 or 2 sessions before the operation and 4 sessions after the operation. We also avoided face-to-face contact. So in the breast cancer study, we had a almost completely digital intervention with only very limited therapist guidance who met patients only 3 times for 50 minutes by video. And in the other case, we had an individual intervention, but through video calls. And our choice was to only target at-risk patients. So we first screened patients and that they have high anxiety, that they have high pain catastrophizing, and only those patients were given an intervention really targeting these factors. So as I said, no results yet here, they're ongoing, so results will be probably in about 1 year. So this brings me back to the title of this my talk, and the whole symposium is centering around this. There is this need for intervention. I hope I convince you of that. And it's not only a need to have effective interventions, but also to make it accessible for as many patients. And I think all the other talks will also go into this respect. So I leave you here. Thank you for your attention, and I hand it over back to Rianne.
Shall I just jump in? I think I'm next up here.
Oh, thank you, Madeline. Thank you for your excellent talk. And indeed, Katie, you're the next one. You would like to introduce yourself. So please go ahead.
Yes, let me share my slides. Hopefully you can see my presentation.
Yeah, exactly.
Perfect. Okay, thank you, Madeline. You set this up with all the things that I needed, so mine hopefully makes sense here. I'm Katie Hadland-Smith. I'm an associate professor in the Department of Anesthesia at the University of Iowa. I'm a pain psychologist by training. For those who are not familiar with geography of the United States, Iowa is sort of in the middle, and it's very rural, and that becomes important in terms of the sample that I'm going to talk about in this work. I don't have any conflicts of interest. I've had some support from the Veterans Health Administration. I am not speaking on behalf of the government. I am presenting my own views. So I'm going to present some data from a pilot, and we have a larger trial ongoing, which I'll give you a little status update of where that is at the end. But the pilot was for PEPS, so it's the perioperative pain self-management intervention. It was an RCT comparing PEPS to standard care, and we really wanted to look at preliminary efficacy as well as feasibility, trying to prevent prolonged post-surgical pain and secondarily prolonged opioid use. And the pilot data are published, so the citation is at the bottom there. So the study design, so it was a single site, so again from Iowa City, a randomized controlled trial. The control arm was standard care rather than another intervention. Our participants were 110 United States military veterans who are being seen in the Veterans Health Care Association. All of them were rural dwelling for the purposes of this intervention. And it was a mixed surgical sample, which I will talk a little bit more about further in, which is a decision that we veered away from a little bit for the larger trial, but we piloted with a very mixed sample. Data collection were primarily preoperative and then 3 months postoperative. For the larger trial, we're going to 6 months postoperative. And it was a mixed methods analysis. So we've got quantitative data and we've also got some qualitative data to supplement. So the actual intervention, so we very much wanted this to be accessible. So our population was primarily older adults who are rural dwelling and who were lower resource on average compared to the US population because of who's served by the Veterans Health Administration. So our intervention is telephone based, and we started piloting it before COVID, before telehealth was spread as widely as it is now in the States. And so we thought the easiest thing to get to the most people would be telephone, so we don't have to worry about things like broadband access. So it's a 4-session telephone intervention. Each session is about 30 minutes. 1 and 2 tend to be a little longer than 3 and 4. Session 1 is an introduction to pain and stress connections. This is built based on principles of CBT for chronic pain, but it's a very light version and of course modified to acute post-surgical pain. And then in session 1, we also introduced relaxation and we practiced a diaphragmatic breathing and a guided visualization. And session 1 occurred prior to surgery, ideally 1 to 2 weeks, but really it ranged between about 6 weeks and 2 days before surgery, but most we tried to hit that 1 to 2 week window. The second session was 2 weeks post-op, and so we reviewed relaxation practice. We had invited people to practice on a regular basis between session 1 and session 2, and then we began to introduce thoughts around pain, interpretation, and doing some tracking of pain-related thoughts. Session 3, we did more work with thoughts. We did a very, very light version of cognitive restructuring. I call it coping thoughts here. And we also introduced goal setting and invited them to set a goal, often in relation to their post-surgical recovery. Session 4 was really a review and wrap up, and we asked everyone to identify skills that they might be willing to continue using moving forward. And so again, the timeline was 1 preoperative session and then sessions at 2, 3, and 4 weeks post-surgery with the encouragement to continue using skills beyond that. And everybody had a workbook to work from as well. I apologize, there's a lot in this table. There are just a couple of things I want to point out. These are baseline demographics. The first thing is that the demographics didn't vary significantly between arms, so randomization worked pretty well in that regard. The other thing I want to highlight is the demographics of the sample are specific to this healthcare system and to this area of the world, and that our population was primarily male, older, and white non-Hispanic. So just to be aware, this was representative of our clinical population in this area, but not of the United States or certainly the world population in terms of demographics. In terms of the surgery types, so we know that there are different rates of persistent post-surgical pain and different surgery types. And so about half of our patients in each arm were getting total joint replacement. So this was knees, hips, and shoulders. Then we had a few more minor surgeries, hernia repair, cholecystectomy, and then just a couple of thoracic and breast surgeries, which tend to be higher rates of chronic post-surgical pain. But you can see the distribution between arms really fell out pretty nicely in terms of making sure that we didn't end up with all of our surgeries with higher rates of chronic pain falling into one arm or the other. So we're pretty happy with how this fell out. And this is just among the study completers because this is ultimately who we're comparing the data on. Okay, so our results. So our primary outcome was pain at 3 months, and we divided it into none to mild versus moderate to severe. So we went with more than 3. Looking at the prior presentation, I kind of want to go back and do a sensitivity with how it would look if we included 3 as the more. But for this purpose, we did it 4 to 10 was considered significant pain, and we found a difference. So 26% of standard care still had significant pain at 3 months, and 9% of our PEPS participants. We also did a per protocol analysis, and the effect was strengthened when we didn't include a couple of participants who were randomized to PEPS but didn't complete, or I think didn't even start the intervention. We also, of course, controlled for preoperative pain in this analysis. And then our main secondary outcome that we looked at was prolonged opioid use. We looked at this in a not the most sort of rigorous way, I would say. We just looked at presence or absence of opioid use at 3 months. We did not find a difference. It was 15% in standard care versus 2% in PEPS. It was not significantly different. When we did the per protocol, it did become significant, but in the main analysis, it was not. And so one of the things we've modified for the larger trial is that we're looking at a time to opioid cessation variable so that we can get a little more nuanced with our data. Because appropriately, the majority of participants were not taking opioids by 3 months post-op. We also included a number of tertiary outcomes, mood-related, function-related. We didn't find significant differences between arms. We weren't powered to, but we will continue to look at some of those tertiary variables in the larger trial as well. And then we did some qualitative analyses. So we did interviews with 21 participants. This is the point that my 2 qualitative experts told me we reached saturation. They did inductive and deductive coding, and the interview was really asking about feasibility, treatment engagement, and satisfaction. Some of the main sort of impacts that came out of this, participants talked a lot about coping with pain and how they use the PEPS intervention in relation to how they were coping with their post-surgical pain. They talked a lot about medication and how they use coping skills and how they use medication and how those things work together. Intervention accessibility, for the most part, people liked the phone as an intervention modality. It was seen as easy. And then the other thing that emerged is that participants really valued the social support. And in some sub-analysis with the qualitative data, it seems that this may have been perhaps more important for participants who are more distressed at baseline. Having those post-operative contacts was highly valued. In terms of the coping with pain, so they talked about learning actionable skills, having a sense of accountability to report back to someone to say, I actually practiced my relaxation, I actually tried to achieve my goal, etc. And then there was also this sort of shift to not focusing as much on pain. I won't read the quotes, but there's a couple of participant quotes up there, and they sort of characterize 2 of the main things that participants talked about. Some participants talked about really using specific skills, and some participants talked about more of a diffuse sense of relating to their pain in a different way throughout the course of doing these sessions. The use of medication discussion, I found these data pretty compelling. People talked about having additional options as well as medication. So it wasn't either or, it was both on, and being able to like extend time between doses, have options, have some sense of choice and control in terms of coping with their post-surgical pain. So the next steps, now we've moved on to the larger trial. This is a 4-site trial. We are narrowing to 3 surgery types. They're all arthroplasty, knees, hips, and shoulders. We've actually very recently completed our recruitment, and we will hopefully have some data to present late summer. And that, I believe, is what I have for you. And I believe Sam is up next.
Yes, thank you, Katie, very much for an excellent talk indeed, Samantha Mains. You are next, so you may take over and you are willing to introduce yourself. You told me.
Yes.
Yes.
Just trying to get my other screen up here, sorry. All right, hold on one second, sorry.
We saw it perfectly.
Oh,
Sam.
okay. All right, that's interesting. I could not see it on my own end. Let me go back to sharing then. Okay,
Yeah,
I'll
there
get
it
there.
is again. Yes.
Awesome, thank you.
Thank you.
Sorry, y'all. All right, hi, I'm Sam Mines. I am also a pain psychologist. I think as many of us on this call are. I am an assistant professor at Harvard Medical School and work in the Pain Management Center at Brigham and Women's Hospital in Boston. Disclosures. All right, so I am excited to tell you a little bit today about a study of a brief mindfulness-based cognitive behavioral therapy intervention for people undergoing total knee replacement. Nearly a quarter of the global population experiences symptomatic knee OA, and as the age distribution shifts with increased life expectancy, that number will likely also increase. We know that TKA is the most common surgical treatment for end-stage knee osteoarthritis. And while most people do very well with it, somewhere between 10 and 34% of people experience chronic post-surgical pain after TKA. And as Madeline mentioned, we know that preoperative psychological distress, including pain catastrophizing, depression, and anxiety, are all known to contribute to TKA outcomes. So addressing these risk factors may improve our surgical outcomes. We know that both cognitive behavioral therapy for chronic pain and mindfulness-based therapies are helpful in reducing catastrophizing, depression, anxiety, and pain in chronic pain populations. And so we aim to use this mindfulness-based CBT intervention in the perioperative period to see if that would help for TKA. So we had two aims for this study: to assess whether this brief MB-CBT intervention could enhance the efficacy of TKA for improving pain and pain-related disability, and then also examining changes in pain catastrophizing, depression, and anxiety as mechanisms of change for MB-CBT. So we in our lab are not just interested in the intervention and whether or not it's helpful, but what are the mechanisms of change, and although beyond the scope of this study, for whom these interventions work best for. So this is a small pilot. We had 44 adults who were 45 years of age or older undergoing unilateral TKA for knee osteoarthritis. And they were all recruited from Brigham and Women's Hospital in Boston. So a bit different than Katie's population. We do have a homogeneous sample in the context of race, which I'll get to, and ethnicity, but a little bit more gender diversity. We recruited 22 participants for this MB-CBT trial, and then the other 22 participants were age, race, and sex match controls from a large cohort study that was aimed at predicting outcomes of TKA. So there was no intervention for that study. The MB-CBT intervention was adapted from cognitive behavioral therapy for chronic pain and mindfulness-based stress reduction, which, as I mentioned, are both evidence-based interventions for chronic pain. We used a 4-session format. These were individual sessions with a pain psychologist, me, and we really aimed to maximize the flexibility. So again, highlighting what Madeline was talking about, not only did we make this brief by trimming it down to 4 sessions,
But there was flexibility in the timing. So the first session could be as early as 4 weeks before their surgery. And the final sessions for everyone were 6 weeks post-surgery. The first and last sessions were in person, and these coincided with their baseline and follow-up visits. And so we did those at the same time. The second and third sessions were done via telephone. Again, this was also pre-COVID. And so, again, much easier at the time than using video teleconferencing. And participants had to have at least one session prior to surgery. A good handful of them did both the first and second sessions pre-surgery, but there was some variability. The sessions outline are here on the right. So in the first session, we provided psychoeducation about pain and the biopsychosocial model of pain. We practiced a body scan, discussed physical activity, and assigned home mindfulness practice that included that body scan. In the second session, we discussed automatic pain-related thoughts, did a mindful sitting practice, helped the patients to engage in mindful reappraisal of negative pain thoughts, introduced activity pacing and sleep hygiene. In the third session, we helped them to identify nourishing activities. So these involved kind of a combination of self-care and pleasant activity scheduling, other healthy coping strategies, and did a mindful breathing practice. And then in the final session, we did a mindful acceptance practice of pain and difficult thoughts and emotions, did a loving kindness practice, and then set them up for relapse prevention, talking about what skills they'd be using going forward. For our primary outcomes, we were interested in pain severity and interference, and as potential mediator variables, pain catastrophizing, and then depression and anxiety using the PROMIS short forms. We collected all of these at baseline, 6 weeks post-op, 3 months, and 6 months post-op. So here is some information about the sample. So the average age was about 67, and we did have a good match between the groups. They were also well matched for sex and race, so our matching worked well. Just over half were female, and about 10% were Black. So this was a primarily Caucasian sample. There were no differences in baseline BPI severity or interference, and the patient's averaged baseline pain was 3.5, which is in that mild to moderate range. There were no differences in catastrophizing, depression, or anxiety at baseline. So although we did not match on those variables, we did not see any significant differences there. In these graphs, you're going to see pain severity on the left and pain interference on the right. And these are shown across each of the time points from baseline out to 6 months post-op. And as you look at pain severity, you're going to notice that there were no group differences at 3 and 6 months post-op. However, the patients who received MBCBT showed a greater improvement compared to the treatment as usual group at the 6-week mark. And although there was a similar pattern in the pain interference outcome, this was not significant. Here you'll see the results of the mediation analyses, where we examined catastrophizing, depression, and anxiety as mechanisms of change in pain severity and interference. And we found that the people in the MBCBT group had a significant reduction in catastrophizing from baseline to 6 weeks, a 6-point change, which is pretty good. And the treatment as usual group did not change. They only had a mean reduction of 1 point on the PCS from baseline to 6 weeks. And as you can see in that top figure, the change in catastrophizing was a significant mediator of change in pain severity, where those in the MBCVT group had a greater reduction in pain catastrophizing, and that was associated with greater improvement in pain severity. The same thing was found for pain interference, though depression and anxiety did not mediate the effects of MBCVT. So we found that compared to treatment as usual, MBCVT seems to promote a faster recovery following TKA. And this is especially important as early movement and engagement in physical therapy is vital in the early perioperative and postoperative period. MBCVT may promote an earlier return to activity, though this is a mechanism that we'd like to study more in a larger trial. We also found that a reduction in negative pain thoughts or pain catastrophizing is associated with improvement in pain severity and interference at 6 weeks. And this provides further support for these interventions aimed at reducing negative pain thoughts, especially in the perioperative period. Somewhat surprising, depression and anxiety did not mediate the effects of MBCVT, but our sample had a pretty low level of depression and anxiety at baseline. So PROMIS T-scores have a mean of 50 for the population, and our depression and anxiety levels at baseline were below 50. So it could be, as again, Madeline was mentioning, that we need to be targeting a group who are at higher risk, which is something that we did not do in this small study. And then I want to mention the flexibility of our MBCVT protocol. So this may be seen as a weakness in that not everyone had the same trajectory, with some having 2 sessions preoperatively and others just 1. But I do think this is a real strength. And so often our interventions are really not able to be implemented in the clinic due to logistic issues, and especially in the perioperative period. But keeping our interventions flexible, we may be able to improve the chances of uptake, which I think Dr. Devon will be talking with us a little bit more about in just a couple of minutes. So obviously this is a very small pilot trial, not randomized. We were not able to look at treatment moderators, but I think this provides some good preliminary evidence, and looking forward to following this up with a larger scale study. All right, and I think that is all. This is thanks to NIH for supporting this, and this is my big team. There we go, and I think I'm turning it over now to Beth.
Yep, sure. Thank you, Sam, for your excellent presentation. Beth, you're next.
Terrific. Let me see if I can get my slides up here.
May I remind everybody that you can still put some questions in the question and answer section.
Are you seeing the correct view?
We see the correct one, but we only need the presenter mode because we.
Let me see if I can. How's that?
Yeah.
Okay,
Very,
perfect.
very nice.
Great. Yeah. Well, thank you so much. I am Beth Darnell, and I'm a professor at Stanford University in the Department of Anesthesiology, Perioperative, and Pain Medicine. And I direct the Stanford Pain Relief Innovations Lab, and really delighted to be here and present on this topic with you. My disclosures, you can see my funding here. I am going to be speaking about empowered relief as one of the interventions we've been studying in the perioperative space. While I created Empowered Relief, it's owned by Stanford University, copyrighted, trademark, and I receive no personal monies. For Empowered Relief, Stanford does receive fees for CME workshops that are hosted at Stanford. So our overarching question, and I guess clinical conundrum, is how do we help people have less pain after surgery? And this has been of increasing importance in recent years as there's been a very keen emphasis on reducing opioid prescribing and really looking for alternative ways to help people get best outcomes. And also just with our, focus on whole person approaches to pain management and recovery. This has actually been a question that's been asked for some time. We've had a lot of national guidances in the United States, institutes, agencies putting out calls for the field to better integrate behavioral medicine and psychological approaches to pain management across the continuum of care, and that, of course, including the perioperative space as a way to just treat pain more comprehensively and to help people get best outcomes at lowest risk. So I am certain this is true internationally. We've just been tracking this pretty closely in the United States. And while there's been consistency in these calls, we really haven't implemented well on these calls to action. And purely from the perspective that there have been barriers in implementation. And Dr. Meintz nicely touched on this towards the end of her presentation, where she was really referencing that, there's a need for flexibility when we're talking about behavioral interventions in the perioperative space. And Dr. Davin will also be speaking on this as well. When we think about the main barriers to integration, a lot of it has stemmed from this multi-session format for our traditional evidence-based behavioral treatments, where it's 16 hours or more of treatment, and just recognizing the impracticality of that, particularly within the perioperative space, and a lot of our patients needing asynchronous treatments. And so if we think about how we're going to get people access to this type of low-risk care, we really need to be thinking about brevity and systems that ensure better accessibility. And so this entire webinar is really targeting that piece, because there's been some really innovative work, and this panel is designed to showcase that innovative work that we are doing to really address this element. How do we package our interventions, deploy our interventions in a way that can be accessed by patients more easily? And then, of course, it's incumbent upon us to provide the evidence for that. But this perspective of brief, skills-based pain treatments can really offer both clinicians, patients, and healthcare systems some key advantages to make possible this integration of low-risk treatments that has been desired and called for many years, but not quite possible or available at scale until very recently. Colleagues and I conducted a scoping review of randomized controlled trials that were really focusing on this space. And so that was the genesis and the inspiration for this webinar. It was highlighted that this paper came out today, so you can access it. And so we're really highlighting here these various treatments and what is the evidence for these treatments. We found 20 randomized controlled trials that met our criteria for inclusion in our scoping review. And our inclusion were perioperative interventions that included outcomes related to pain and or opioid reduction 1 month or longer after surgery. And so we went from 1 month to 6-month outcomes for these interventions. And these are the 4 studies that we really highlighted in this article. And you're hearing about all of them in this webinar. I just want to highlight that these 4 studies have all been conducted in the last 4 years or published in the last 4 years. And they all are predominantly or entirely orthopedic surgeries. So we really see that kind of focus in this space. And there's been differences in the modalities of how these interventions both are delivered, as well as some key differences in the content. Although I will say there's more similarities than dissimilarities in what all of us are doing, but it's packaged in different ways and studied in different populations. So I want to highlight one of the studies in our scoping review, which was conducted by Adam Hanley and colleagues and published, I believe it was in JCCP in 2021. And this was really interesting. This was a 2-hour preoperative education program called the Joint Academy. And this was conducted by sort of a team effort that involved nurses, physios, and psychologists. And they uniquely randomized among the psychological aspect of the intervention 3 different pain management techniques. So patients would receive one of these pain management strategies, and the 3 strategies were mindfulness of pain, mindfulness of breath, or a purely cognitive restructuring intervention. And then the researchers wanted to understand, what are the differences in these techniques and how might they operate over time? One of the things I love about this study is that it's really, these interventions are ultra brief. And so it can begin to inspire us to understand what might be the minimal level of intervention required to achieve some meaningful post-surgical outcomes. And the researchers reported that mindfulness of pain had the best effects for reducing pain intensity and pain interference. And both of the mindfulness interventions were superior to cognitive restructuring for opioid reduction at 21 days. So I do invite everyone to take a look at this study. And I think it really inspires us not just to understand sort of like the minimal amount, but also how some of these components might confer different results. So very isolated techniques, and we can see some benefits weeks after a surgery. The other intervention, the other study I want to highlight is one that involved empowered relief, study conducted in orthopedic trauma surgery patients. And this is a packaged treatment, a little more similar to what Dr. Meintz and Dr. Hadlin-Smith described in their studies. And so I just want to give a little background on what empowered relief is, what comprises empowered relief. This is a really didactic intervention to be distinguished from other interventions that are more interactive or might be considered therapy, other interventions where you're working one-on-one with a clinician. Empowered relief is most often delivered in group settings and can be delivered in large groups, either in person or online. It includes pain neuroscience education, some mindfulness and cognitive behavioral skills, experiential exercises, completion of a personalized plan, and participants receive a binaural app that they can put on their phone or personal device and use that ongoingly after they receive this one-time intervention. Now, the empowered relief intervention most often delivered by a certified instructor, the class being 2 hours in duration. But the studies that I'm going to very briefly describe involved a self-paced, video-based version of this intervention for asynchronous delivery among surgical patients. So the basic premise of empowered relief, which is pretty common to many of our psychologically based interventions for pain, focusing on, pain eliciting, naturally eliciting a distressing response, that can be regulated in the central nervous system, equipping individuals with skills to downregulate distress, pain processing, and to gain relief over time by utilizing a basic principle that if we can calm the central nervous system, we are applying that downregulation, which can lead to lasting changes over time. In the chronic pain space, we have conducted many different studies, different populations, different investigators of empowered relief, and it's widely available and implemented clinically now. Largely because it is both packaged and also ultra brief, and therefore feasibly integrated into different settings. You can see it's being delivered internationally, and we get about 15,000 visitors to our app page every month. So we studied this, a self-paced version of empowered relief in patients undergoing orthopedic trauma surgery. This population is to be distinguished from some of the other populations. I think that the other 3 studies that were described more standard orthopedic study populations, so joints, hips, knees. Orthopedic trauma surgery is really different. It can often be younger individuals. And so there's a traumatic etiology. There is less ability to sort of schedule classes, et cetera. So when we conducted this study of empowered relief in orthotrauma surgery, we enrolled people in the hospital after their surgery and gave them an iPad, and they received the intervention on post-op days 1, 2, or 3. And then we followed them longitudinally. This was a randomized controlled trial, and participants were randomized to either receive a health education intervention, which just sort of referenced, nutrition, hydration, other aspects of surgical healing, or they received skills-based empowered relief. And just very briefly, we were really looking to see we were looking at pain intensity as our primary outcome. And so what you can see here is the control intervention as well as the empowered relief intervention over time, 2-3 months. And so what we saw longitudinally was that the patients who received the empowered relief intervention on the iPad reported having 1 point to approaching 1.5 points reduced pain intensity to 3 months after surgery. And this is important because, at least in this particular surgical population, you can see how high pain is. And over the duration of months after surgery, there's often, it's just, typically complex. There may be revisions, there's a rehabilitation process. So it is more complex than some of those other orthopedic surgeries that are non-traumatic. But we did see a meaningful difference, which is useful when we consider that it's so low burden and could be offered on an iPad, for instance. We interestingly we've in our empowered relief studies in surgical patients, we have seen basically floor effects for catastrophizing at baseline, really surprisingly. And so we have not been able to do these great kind of mediation analyses like Dr. Meintz was describing, showing that the effects are mediated through catastrophizing. We actually are putting forward some evidence that these interventions work in the absence of psychological factors at baseline. And this is a second study I just briefly want to touch on before I turn it over over to Dr. Davin. We did a similar study in women undergoing surgery for breast cancer, and we wanted to understand if it would reduce both pain and opioid use after breast cancer surgery. And this was 68 women in the study. And we did find that the women who were randomized to this digital version of Empowered Relief had required about 1 week less opioids after their surgery. And that was really interesting because we don't reference opioids, reducing opioid use in Empowered Relief. And again, there was a floor effect for catastrophizing. So it's not operating just through that very common and highly predictive psychological construct. There are other pathways by which this intervention, and I believe all behavioral interventions, are working. In terms of acute pain, it is most commonly delivered live by an instructor over Zoom, and we have tailored versions for acute pain, for surgical pain, and also for veterans with acute pain. It is being offered as standard care in many healthcare organizations in the United States, in the NHS in the UK, and in Canada. And these are just some of those organizations that are offering it. So to our knowledge, I would love others to chime in if this isn't accurate, but to our knowledge, this is the only perioperative behavioral intervention that is widely being implemented clinically. And I think that sets the stage for Dr. Davin to tell us about her experiences with clinical implementation at Cleveland Clinic. And with that, I would just say thank you for your time and attention.
Thank you. Thank you,
Stop
Beth.
sharing.
Very great presentation.
Thank you. Let me just see if I can. Am
So
I still sharing, by the way?
Yeah, you're still sharing.
Okay, let me see if I can figure out how to stop sharing.
Yeah, thank you very much. That's
Perfect.
all right.
Okay, great.
Well, Sarah, you're next. You're already announced by Beth. So if you could share your screen and
Great.
give a short introduction of yourself. Thank you.
Sure. Can everybody see my slide?
Yes.
Yes.
It's perfectly.
Very good. Fantastic. So excited to be here today, and such great presentations by my colleagues here that I think really demonstrate strong efficacy for behavioral interventions in the perioperative space. My name is Sarah Davin. I am the director of the Center for Pain Recovery, which is a center of multiple clinicians, all really dedicated to serving the most complex patients with chronic pain. We have pain physicians, psychiatrists, pain psychologists, social workers. We work side by side with PT and OT. Our team within the last couple of years has moved within the Center for Spine Health, and we are also involved in the surgical care now of patients, which is the focus of my presentation. In addition to being the director of that team, I also am a pain psychologist, and relevant to this presentation is my background is in public health as well. So I have a very strong interest in broadening these interventions in program development and making big changes, particularly in healthcare systems. My presentation is going to be a little different than the previous ones in that I'm going to be speaking from the standpoint of how this can be integrated into a clinical pathway. And I'll be speaking a bit about the feasibility and the process that we took to make this part of standard of care for individuals with spine surgery. Okay, is it going to let me advance? There we go. Disclosures, I am an Empowered Relief certified instructor. I also am part of the workshop faculty and receive an honorarium for that. The goal today is to describe the integration of Empowered Relief, which Dr. Darnell just highlighted beautifully, into the standard of care for individuals with spine surgery. The Cleveland Clinic is a large multi-specialty medical center. We have locations, multiple locations in Ohio, Florida, Las Vegas, London, and Abu Dhabi. I'm going to be focusing on our Ohio location today. We do broaden out to the Florida group as well. We tend to see patients that come to us with very high complexity. They're coming to us because oftentimes they want a specialty consultation for a problem that perhaps they have not really gotten answers for, or that has been persisting, and they're really hoping to find something to help them. We do also see international patients, and we see a good number just locally from the state of Ohio. The Center for Spine Health, the Ohio version, we do about 3,000 spine surgeries a year. We tend to see patients alongside with what I mentioned about the Cleveland Clinic as a whole that have high levels of complexity. So it's not as common for us to do first spine surgeries. We're often seeing patients that have had chronic pain for a long time. They've had multiple surgeries and multiple overlapping medical and psychiatric comorbidities. So as a psychologist, as part of a multidisciplinary team with large representation by physicians and surgeons, we are constantly looking at ways to improve our clinical care. And a repeated theme that was coming up over the years was that our spine surgery patients were really challenging on the inpatient side, and we saw really a great opportunity to help control their pain as well as to improve their outcomes and their patient satisfaction overall. And these are things that are really important for large hospital systems to demonstrate and look at. And so over time, these discussions were coming about, and we identified these three areas that were really high value targets for opportunity, with the hope of integrating behavioral interventions into the population to not only enhance outcomes, but to reduce things like readmission rates and recurrent emergency room visits that would occur after surgery. This sounds easy, but it's a huge challenge, right? We're part of a very, very big system. Psychology, even though we are at the forefront now more than ever, there still is a tendency for non-psychology, non-mental health providers to look at psychology as sort of the last step, right? It's only for the patients that have failed everything, and they can really obviously see, they meaning the medical professionals can obviously see are distressed psychologically. So the big shift here was trying to change that culture and really put psychology in alongside and equal to all of the other things that are delivered in the perioperative pathway. The challenges definitely are there, just in terms of the pathway being quite busy. Nurses already are feeling overly burdened, and patients have a zillion appointments even just before surgery. We also knew that we wanted to be able to do this in a way that we could provide services to patients that were local as well as out of state and beyond. So, lofty goal, but the goal was set that we wanted to integrate behavioral pain management as part of best practice standard of care for all of our spine surgery patients at the Cleveland Clinic. We chose to utilize empowered relief, which we were also already using as standard of care for our chronic pain patients, and it was showing great engagement and success. Dr. Darnell already spoke in detail about this intervention, so I'm not going to go into that just for the interest of time. We were offering these classes primarily for the chronic pain population. We were doing them virtually with a live instructor over Zoom for Healthcare, and we were offering them once a week with certified instructors. Group sizes initially were about 10 to 12 patients. So I'm going to talk a bit about our phases of clinical implementation. Once we established this goal and this need, we really had to identify a core group of stakeholders. We needed leadership's buy-in, who could really message this to all of the physicians and surgeons and the nursing staff that this was a high priority. We started a group, we met often so that we could really work on a process and a workflow to make this feasible. We included ways to order the class and to work with nursing to make it low burden, and I'll speak a little bit about that later. We chose to start with just 2 surgeons who were really interested in this, that were going to champion this effort, and we piloted it with those 2 surgeons. And with that, we were able to demonstrate strong feasibility as well as really high rates of satisfaction. I think in that initial pilot, we had about a 60% engagement rate, meaning that of all the patients that were scheduled, 60% were showing up. And this was just in our initial pilot. So we reconvened, and again, we decided that we wanted to move forward because we demonstrated the feasibility and acceptability, engaged the stakeholders again, and we decided that we were now ready to expand this to all of our main campus spine surgeons. And to do this, we really had to, the amount of education for the providers and the staff was really crucial, and also making sure that we were constantly checking in, really mostly with nursing, to be honest, so that they were not feeling stressed and overburdened, and they could also message to the patients the importance of this class, right? So one of my first meetings with nursing, they hated the idea, and they were really, their biggest concern was that the patients were going to think that we were calling them crazy and we were referring them to a psychiatric intervention. So we had to work with them on, this is the language to use, and this is the purpose of the class. Phase 3, we demonstrated that we were able to get it rolled out to the main campus. Then we started to look at our regional facilities. We picked 2 other regional facilities that are relatively close by that also do spine surgeries, again, in services, education. And we then saw a need to have an inpatient presence. So we developed that through a pain psychologist whom we have, who can be on the units, educating the nursing staff and really reaching out to those patients that are high risk, seeing if they have had the class, because this is delivered before surgery, and or scheduling them for follow-up after surgery. We also decided to survey patients to see what they would be interested in post-operative support, because again, this class initially was timed to occur before surgery, typically anywhere between 30 days to a couple days before surgery, with a bit of variability. But we were seeing that patients were really, really appreciating this information, and so grateful. With every class, I felt so rewarded because they were just really soaking up this information. And so we sent out surveys to patients that had attended the class to get a sense of what else they would offer in the post-op, what else they would want to be offered in the post-op period. And I'll talk a bit about what we found with that. We have developed a post-op group, and we are actively getting ready to implement some self-paced guided digital technology to utilize empowered relief for these patients. Currently, we are seeing that 75% of our patients that are scheduled for this class attend. Now, they are pretty much automatically scheduled unless a patient is saying, there is no way, I'm refusing to attend. I do not want to do that. So we're not forcing them, but we're strongly encouraging them. So 75% is really great. It's an improvement from that initial pilot. And I think a testament to the power of education and this culture change, so that all of the staff are really embracing this. We've about 1,000 patients have taken the class. We have expanded it out to larger groups at this point, up to 50 patients as well. And we're continuing to see really high rates of satisfaction and acceptability. What you can see here is the items that from our satisfaction survey that is sent out to patients immediately after they take the class through REDCap. They can do it and respond. And we have, as you can see, really, really good rates of satisfaction. I'm not going to read through all of these comments, but I just want to show that, you know, some of these comments I think really speak to just the experience of patients, which is so important as they're going through this class. The top one is a notation of being skeptical right before the class. And I think a lot of patients, especially when they show up, we have to kind of reorient them to how this is really going to support them in their surgery and beyond. Again, a lot of patients, this is the theme around it being very informative and how they're using the information in terms of using the breath exercise and developing their list of self-soothing behaviors. So we go through this with them in the session. We talk a lot about, especially for the post-op period, having that list of self-soothing actions that they're going to do during recovery. So we're trying to get them thinking in the post-operative period while we see them before surgery. And certainly the presentation style has to be positive to, I think, form that relationship. And then we also have some comments from folks that responded after their surgery and found it to be quite helpful. So what's next? Well, I'm excited to share that our entire center has embraced this so much that so every year we have to come up with ways to measure our team's success. And this, we report all the way up to our chairman on these OKRs, which are measurable goals. 2 of our OKRs related to surgery out of 3 are all about this. They're all about using empowered relief, improving engagement, and demonstrating outcomes. So there's really, I think that's fantastic that all of the stakeholders are really invested in this. We are also wanting to expand our inpatient presence. We're getting, I think that's really successful. So recruiting more psychologists and looking at how we can do that. And we are looking at outcomes, and particular those high value targets that I mentioned initially, and also looking at the impact of these interventions on healthcare utilization. So I'm not going to speak about that yet, but it is in process. This slide just is a summary of what we did find in terms of the post-surgery support preferences. So 45% of those that attended and filled out this questionnaire, some of them did not, said they would like a post-surgery group. Most prefer an on-demand class that they can complete on their own time. And you can see the breakdown for frequency of contact. About 46% want to be contacted 1 time post-surgery, and about 41% would prefer 1 time a month for 3 months. And I'm going to just show our pathway. This was the care path for sort of the workflow in terms of how we've done this. So you can just see that once they are deemed eligible for spine surgery, we then have an automated scheduling system. An order is placed, and then there is communication that is deployed to them through MyChart. And we obtain outcome measures from those patients. We continue to follow those people that maybe did not show or had not had the class and identify them on the inpatient side, where we also do target those patients that we can get to that have had our class on the outpatient side. We want to sort of reinforce the skills while they're inpatient and see if they need additional support outpatient. We do have plans to deliver the online program with the digital technology, and that will hopefully allow us to expand our reach. And then we have also other options post-operatively to support patients. We do have a pain rehab program. We offer ketamine infusions, and of course, physical therapy is essential. Just a few key guideposts for clinical implementation. If you are a clinician that is interested in utilizing this and adopting it at your organization, as I mentioned, education and ongoing education for both the providers and the patients is crucial. We have to ensure that the patients understand that this is best practice, right? This is coming from national recommendations that this should be integrated into the care path for surgical patients. And we have to continue to engage the stakeholders on the provider side. Certainly, as others have mentioned, brevity and using multiple modes of accessibility to support engagement on the outpatient side and the inpatient side is also recommended. We have found that having additional touch points beyond that initial pre-surgery class is useful. And really that's just reinforcing the skills that we have taught them. And that can be done in a variety of ways. It could be, groups, it could be text messages, it could be an app, it could be one-on-one sessions. And so I think that speaks to Sam's point about being flexible. While it is a limitation when we're looking at, randomized controlled trials, in the clinical pragmatic application of this, we do have to have some flexibility in how we're going about this. And also, I would just like to emphasize the need to really look at outcomes on an ongoing basis to reassess and to ensure patient response. But as I noted, we have found this to be really well received by our spine surgery patients who have high levels of complexity, both on the medical side and the psychiatric side. If you'd like more information on our process for clinical implementation, this is our article, Transforming Standard of Care for Spine Surgery. That was in Frontiers in 2022, so I encourage you to check that out. Thank you very much.
Okay, Sarah, thank you very much also for your excellent talk. We still have a few minutes, so we'd like to start the Q&A session. We have several questions, and the first question is about that, like chest physio, CBT should be a part of preoperative and postoperative orders for better pain care. But are there also other breath skill basic strategies to reduce pain? And I think that question was during the talk of Beth. Not sure.
Interesting. Yeah, well, I also invite all of the speakers to chime in on this, but I do wonder if this question was specifically referencing Dr. Hanley's publication, where they were studying mindfulness of pain, mindfulness of breath, and cognitive restructuring and comparing those. So I think that, that article can really outline those strategies used. I think in all of our presentations and all of our treatments, we are referencing utilization of a relaxation skill, engaging the breath, whether it's mindful breath or just general relaxation. So I think, the question is, are you going to integrate that in as a standalone or adopt a little bit of a fuller picture, including some of the explanation and recommendations around it? And that is contingent upon your needs and your clinical capacities.
Thank you, Beth. I have one more question, and this is for Dr. Meins. The question is, I'm interested in how Dr. Meins talked about sleep hygiene. Can you explain on the link between sleep and persistent post-surgical pain, please?
Yeah, the link between sleep and pain in general is quite strong, and there is quite a bit of work. Michael Smith at Johns Hopkins has really done a lot of work in this realm, and in fact has a trial right now of cognitive behavioral therapy compared to, cognitive behavioral therapy for insomnia, CBTI, compared to CBTI plus bright light therapy in the perioperative space for people undergoing TKA. So more to come on that, but we do know that CBTI in general is helpful for improving sleep in the perioperative period, and that does seem to be helpful for pain outcomes as well. So in short, it is very important. And as anyone who has been in the hospital knows, it's really hard to sleep in hospitals. So getting some extra help on that is great.
Yes, thank you. Just the next question is about empowered relief. And the question is if empowered relief can be used by physiotherapists in treatment.
Yes, it can be. And we offer clinician certification workshops through Stanford University. These are 2-day CME workshops. And once a clinician goes through the 2-day workshop in total, they are able to deliver the intervention to their patients. It's interprofessional, so physical therapists, physicians, social workers, psychologists, anyone who's a licensed clinician. So I was trying to target 2 questions in one there.
Yes, I see that there was another question about that, and you're also
Yeah.
typing an answer. I saw that. Yeah, thank you. Well, I have a little bit, 6 questions already answered, I see, but I have a last question, well, almost the last question, and it is about the IASP has put forward the concept of nociplastic pain, pain that will not respond to surgery, pain that appears to be the consequence of stress, ACEs-induced changes in pain processing, and it is thought to predict perioperative problems with pain control, prolonged opioid prescribing, and there's evidence that treatment reduces pain, about Lumley and colleagues, for example. I'm not yet hearing any work on identifying nociplastic pain preoperatively and developing interventions. What do we know about this? I hope this question is clear to you.
Go ahead, Sam, please.
Oh, so I think one of the things that's worth considering here is that if somebody has what is presenting as purely nociplastic pain, they likely wouldn't be a surgical candidate. And so or they would be a poor surgical candidate. That said, I think there's a lot of evidence to suggest that many pain conditions that do seem to have an pathophysiological etiology outside of nociplastic pain may also have a nociplastic component. And so I think that is perhaps what all of these interventions are trying to get at, is not just in the acute period, but why are they developing a chronic post-surgical pain? Perhaps because some of their pain was nociplastic to start with. So I don't know that we're accurately identifying it in the preoperative period, but I think we're in a roundabout way trying to address it.
Yes, thank you very much.
Yeah, and if I may add to that, we do know that there's a lot of evidence that having any chronic pain condition before surgery is a predictive factor for later chronic post-operative pain, and also these psychological factors which have been identified. So it might come together in this nociplastic pain. So I would think that these were the most excellent candidates to offer an intervention to prevent later harm from happening.
Yes, that's a great addition. Thank you, Madeline. I see 2 more questions about elaboration on the training involved to deliver empowered pain relief.
I
Yes.
put in the link if anyone's interested in learning more. The certification workshops are 2 days, and they're all online. And we do offer scholarships, need-based scholarships, if people have financial hardship.
Okay. Yeah, thank you very much. I think that those were all the questions. Let's see if I missed anything. Just one question for the speakers. We're almost at the end of this session. Is there anything that you would like to add to this session to end it, or are you just done?
I will just say thank you to the Acute Pain SIG for hosting our topic and giving us this opportunity to share our work and our excitement for the evidence around brief skills-based interventions. I also want to thank all of the speakers on this panel and you, Rianne, and Madeline, for giving us a really terrific introduction to the importance of this topic.
Well, thank you very much. Then it's quite 9 o'clock, at least in my country, it's 9 o'clock, but that of course that differs around the world. But we are coming to the end of this session. So I would like to thank you again, all speakers and participants, for your excellent contribution, but also for your excellent questions. I think this was a wonderful workshop, and it is recorded, and you can see it again if you would like to, or tell other people to watch it on the IASP educational site. So thank you very much. Usually, Renee, I think that you would like to close it. Is that the case for now?
That would be wonderful, Rianne. Thank you. We've come to the conclusion of our webinar, Upskilling Pain Relief After Surgery, Perioperative Behavioral Intervention, Efficacy, and Practical Considerations. I want to thank once again Madeline, Katie, Samantha, Beth, Sarah, and Rianne for being here today, as well as Dr. Gregory Carbonetti for his help coordinating this event. As a reminder, the recording of today's webinar will be available on IASP's Pain Education Resource Center, and we encourage all of our IASP members to enjoy the other offerings available there. If you are an IASP member, please consider joining us again tomorrow on the 6th of February at 5 p.m. Eastern Standard Time for an all-member town hall with IASP leadership. Thank you all for your participation today. Take care and all the best.